Good morning. Happy Thursday and welcome to day 3 of OMTEC. Today is another packed day, starting with our morning keynote panel of surgeons who will continue our conversation about the future of the orthopedic industry. And I would like to thank our sponsor, which is Sinai Fracture Care International. David Jensen is a longtime volunteer and supporter of Sinai. And before he says a few comments, we are going to watch an inspiring video about how Sinai is impacting orthopedic care.
Thank you, Sinai Fracture Care International.
Good morning. My name is David Jensen. It's an honor to speak to you this morning about Sinai Fracture Care. Sinai Fracture Care is a humanitarian organization that has developed the resources and capacity to design, manufacture, educate, and deliver orthopedic implants to developing countries around the globe. It's been a privilege for me to be associated with the organization that has contributed to the healing of 240,000 patients who otherwise would have become disabled and unable to work and care for their families. Dr. Lou Zirkel, a Vietnam vet and traumatologist from Richland, Washington, invested in an idea to engage surgeons in developing nations in an effort to educate and supply them with the knowledge and skills they needed to treat patients with the Sinai intermedullary nail, which is able to treat femoral, tibial, and humeral fractures without the use of a C-arm. Sinai is his passion. Dr. Zirkel visited our facility in late 1990s to ask my boss, Randy Hubner, to help him learn how to manufacture implants and instruments. Many of us joined the cause and the mission. The vision of Sinai is about creating equality in fracture care around the world. Today, Sinai Fracture Care has initiated 340 programs in 51 countries around the globe. Their factory, at organization's headquarters in Richland, Washington, is not unlike many of the shops you have become familiar with in our industry. They continue to pursue and drive the design, manufacturing, education, and supply of simple, innovative implants and instruments to those in need. I have met many of the Sinai surgeons from the developing world as they traveled to Richland for the annual Sinai conference. The number one comment I hear from these surgeons is their gratefulness that an organization has put effort into supporting and healing of the poor. Sinai could use your support to continue and expand its vision to heal patients. Please take a look at the Sinai literature on your table to learn about how you can support our mission. It costs Sinai only $150 to treat a fracture. We would love for you to be part of our mission. If you have any additional comments or questions for me, I'll be around after breakfast if you want to ask some questions. Thank you, and thank OrthoWorld for giving us the shot. This morning's keynote continues the conversation around innovation in orthopedic care and our esteemed surgeon panel. The future of orthopedics is happening now. Progress is being made on materials that increase implant longevity, designs that improve patient outcomes and speed recovery, robotic and computer-assisted technologies that enhance accuracy, reliability, and speed. The panel boasts future-minded surgeon entrepreneurs and researchers who have varied practical experience from the leading edge of tomorrow's solutions. They will share perspectives on what is working in orthopedics, what gaps remain, and how orthopedic manufacturers can develop new, relevant products that solve problems and alleviate pressures for surgeons and hospitals. Our surgeon panel includes Dr. Joshua Jacobs from Rush University, Dr. Kornelis Poelstra from Sacred Heart Hospital, and Dr. Douglas Unis from Mount Sinai. Our moderator this morning is orthopedic industry veteran Dr. Robert Poggie of BioVera. Please join me in welcoming our panel.
Thank you very much. Welcome. First, I'd like to thank OrthoWorld for hosting us and having us and then giving us this forum to speak to you and everybody that came here and supports this meeting, because without you, this meeting doesn't happen. Your interest and wanting to be here. So the objectives of this meeting are really to draw you into the conversation. And the way we're going to do that is we each have 3 slides we're going to present. We're going to present cliff notes of our CV. We're going to give you our perspective on what's worked and not in orthopedic surgery over the last, in our careers. And then we're going to have a slide on what we think is going on in the future. The idea here is that with each of our slides, you will then know our background and what we think and tee up some questions in your own mind to start a conversation. And we will also, of course, discuss topics around our interests that we're going to present here. So to get this going, I'm going to start with myself. So I've been in this business since 1992. I've worked on technologies like oxinium that Smith & Nephew has commercialized successfully, trabecular metal with Implex that Zimmer acquired back in 2004. I have experience more currently in resorbable polymers and biocomposites and surface coatings to enhance anti-microbial implant. Excuse me. So my current work is focused on regulatory strategies based on my engineering experience that allows me to help companies navigate the FDA primarily, secondarily Health Canada. My background in education is in engineering. All 3 degrees were from Vanderbilt University with a focus on tribology, which is ultimately how I got into this business, worrying about wear of hip and knees in the early 1990s. So what's worked in my personal professional experience? I think that this group in this room should be proud that the polyethylene wear problem, in my mind, is mostly solved now. When I started in this business in the early 1990s, it was a big problem. This is all the surgeons could talk about, was osteolysis, loosening, what's going on. And I think the industry came to grips with it through the 90s and into the 2000s. And I would argue today that we have a hip that should last 30 or 40 years. There's no reason why a company can't offer a surgeon and a patient a hip that's going to last that long. Because I really believe that the industry has done a wonderful job dealing with the problem through science and testing. So there's a success story that I think we should all be proud of. The next thing that I think has worked very well is porous metals for fixation. And what I mean by that is trabecular structured type metals. And 3D printing has really enabled, again, any company that wants to spend the money on the cost of goods to get into the 3D porous metal fixation implant business. There's no reason that you cannot have it as a company and offer it for your customers and ultimately the patients. So I think The scientific literature is clear that we in the 1990s and into 2000s have created a new material that is a benefit to patients for sure. Another, I'd say, I could call it innovation, has been incremental since the 1980s, is ceramics in general, meaning both coatings and solid ceramics, thinking total hips, for instance. I think that back in the 1980s, ceramic fracture was actually relatively common, and one reason why surgeons didn't like to use it, common being maybe a 1%, 0.5% fracture rates of femoral heads of the original Biolox alumina. But I think today we can say that for femoral heads anyway, the rate of fracture is minute, doesn't occur often, and I think provides patients a better solution for a bearing surface. And I was very encouraged. I saw a new coating on the exhibit floor when I arrived yesterday that shows that I think, on top of the oxinium knee that we've known for quite a while, I suspect we're going to see other knee products coming out that are either fully ceramic or ceramic coated, and again, very good for patients and I think innovation in our industry. A couple of notes that I think have not worked, and it's principally, I could argue, by design in terms of flawed designs, and I'd say flawed testing protocols that didn't catch the problems. Some of the modularity that happened back in the mid-1990s, and unfortunately again in the last 5 to 10 years, trying to make hips go into very small incisions has not worked out terribly well for the industry. Another area that I think did not work was low stiffness metal alloys, and specifically titanium alloys, to try to quote unquote provide a better stress and strain environment for the femur. I was actually one of the engineers that worked on an alloy like that called Ti 1313 in the early 1990s. And when you think about it, it's not going to solve the problem of stress shielding in the hip by the material itself. It really has to come from a design and materials combination. So that was a couple of examples of things that didn't work in my experience. So where do I think things are going in my mind in the future? I see emerging, I think, of patient-specific technologies with robotics and computer-assisted intraoperative means to put the implants in. I think these things are going to come together thanks to computing power. I see resorbable polymers, a change away from PLLA. I think you'd be hard-pressed to find PLLA, for example, in any sports medicine catalog anymore. So I believe we'll see new biocomposites and resorbable polymers. I think we're going to see coatings that'll finally start making implants resistant to infection, which would be a tremendous benefit to those patients that need it most, like cancer patients and salvage and revision patients. And I believe that ceramics in the 21st century, that means lower cost options, more options for you as we get away from cobalt chrome and reduce further the amount of debris and wear into the joint environment. So that's a bit of my perspective. Again, the idea here is to tee up in your minds questions you might want to ask me after all of us speak briefly about our own history. So next up is going to be Dr. Joshua Jacobs, who's going to give his experience.
Thank you very much, Bob, and welcome to Rosemont, Illinois, right next to Chicago, my hometown. And I'm pleased to be coming to this conference. First time I've been to an OMTEC conference, very impressive. So a little bit about me and why I'm here. I'm actually a fellowship-trained adult reconstructive orthopedic surgeon. What that means is basically I do hip and knee replacements for a living. And I did my residency in orthopedics in the mid-'80s, and a fellowship back here in Chicago at Rush University Medical Center under the tutelage of George Galante, who was one of the pioneers in cementless fixation. And I would agree with Bob that porous materials have really transformed the way we do surgery, and that was certainly a success story. I also run the research program at Rush University Medical Center. I'm the vice president for research. And so a little bit unlike the other two panelists, which are entrepreneurial, I'm more focused in the research area. So I tend to be the skeptic and show me the evidence person as opposed to let's just jump in and try something new. And that's based on a career doing research, which I would say has to do with failure analysis. looking at things that have gone bad, some of the things that Bob mentioned in his talk, modular implants, bad bearing surfaces, trying to understand why they went bad to make them better and to solve some of the problems we see in the clinic. And so I have done a lot of research funded by NIH looking at basically the failure mechanisms in total joint replacements, focusing on the biology of joint replacements, the biology of orthopedic implants, and that's something that we'll talk more about. And I've had some leadership roles in orthopedics, being president of the American Academy of Orthopedic Surgeons in 2013, and before that in 2006 or 7, being president of the Orthopedic Research Society. So my current research focuses on tribocorrosion performance of contemporary hip replacements. I'm not quite as optimistic as Bob that we have the 30-year hip yet, but I think we might be close and we might be getting there, and we'll talk a little bit about that. I tend to be the funnel for every unhappy patient with their joint. Seems to find their way to Chicago to see me because of the concern about metal allergy. This again goes into some of the biological impacts of what we do. And I come to this with a background not only in medicine, having gone to medical school and done an orthopedic residency, but studying material science as an undergraduate. And always during my training, spending time in research laboratories, for example, the biomaterials laboratory at Northwestern when I was an undergraduate, and then in medical school in the laboratories of George Galante, and as a resident in the corrosion laboratory at MIT. So I've always tried to use my background in material science and engineering to really understand what we're seeing in the clinic and how what we're seeing clinically relates to the performance of the materials that we're using. And I think that's been a very effective background for me to contribute to the orthopedic literature. So what has worked? Well, clearly what we do clinically, and that's Doug and I are adult reconstructive orthopedic surgeons. Total hip and total knee replacements are probably the most successful operation known to man. Certainly, it's the biggest advance in the treatment of arthritis and other end-stage degenerative disease in the last century. And some have termed this the operation of the century. And those pictures showing pole vaulters and high jumpers is to say because of the success of this operation, which currently survivorships at 10 years of in the mid to high 90% range, and at 15 years we're approaching that. There's a very high bar to make this operation better. Now, it's not perfect, but it's a very high bar. And unlike the time when Bob and I started to get into this business, you can see from my gray hair, I've been doing this for a while. I've been in over 30 years. Things have changed. Some of the problems we were dealing with and the high failure rates that we saw with the first generation of cementless implants, the first few generations of polyethylene bearing materials, those have been solved. So it's a very high bar now for new technology to make an impact in this field. And I think this is a theme that will come up through our discussion section. So the historical challenges we had in joint replacement when I got into this area in the mid-'80s, aseptic loosening, we have much better materials now to promote long-term biologic fixation, bone ingrowth. And we understand that biology much better than we did. We have better materials. So that's, for all practical purposes, been solved if the implant is put in correctly. Because of the advances in our understanding of tribology, particularly the advancements in cross-linked polyethylene that Dr. Poggie mentioned, where, although not solved, is really we have it tamed. And I think we do have a 15, 20-year hip. Whether we have a 30 or 40-year hip remains to be seen, and there's probably new technologies that can be brought to bear to get to that point. And because we've solved this problem of wear largely, the problem of osteolysis or periprosthetic bone loss, that is inflammatory bone loss around an implant due to the debris from the wear process, that's also been solved. So that's worked. But there are things that have not been solved, and there are current problems in arthroplasty. First and foremost, in my area, what I study is this concept of tribocorrosion. And I think we really understand tribology fairly well in orthopedics. What we understand a little less well, and we're starting to get attuned to it, is this interaction between not only mechanical, the tribological processes, but also the electrochemical, the corrosion processes. And that has been an Achilles heel of ours with some of the modular implants that we introduced recently, the neck modularity and other types of modularity, but also in the typical head-neck modularity that is now the standard of care in hip replacements. There are problems there, and we need to understand those, and that is currently one of the main failure mechanisms of primary total joint replacements in the US. We still haven't completely solved the problem of instability, that is dislocation after total hips, or perhaps instability in total knees. The infection, we've done really nothing with it in decades. After the introduction of antibiotics and special flow and maybe changing our operating rooms to make them ultra-sterile, we haven't changed the infection rate to somewhere around 1%. And so that's where we do need innovation and we need improvements. And then, of course, as good as our implants are, I don't think we are restoring the normal function. I don't feel comfortable letting my patients do whatever they did that led up to the problem of getting end-stage arthritis. I don't think we're there yet, and particularly in total knee arthroplasty. And finally, we haven't solved the problem, and I think one of our biggest problems is variations in surgical technique that can lead to failures, and that's where some of the new technologies that are coming through that you'll hear from other speakers may have a role. So what are our opportunities to improve the future? To utilize the revolution in biotechnology to develop biochemical, biomechanical biomarkers to make appropriate implant choices and or targeted biological treatments. One of the ways that we attack the problems in joint arthroplasty is we make better implants. Another way is to understand the biology of implant failure and to manipulate the biology of the patient who gets the implants. And that's an up-and-coming field, and that's, I think, a very promising future looking at the biology, taking advantage of the revolution of biotechnology, as I said, and the use of big data. Increased durability of total joint replacement device with advanced testing protocols, and this refers to better and better mimicking or simulating the in vivo environment so that preclinical testing can be more predictive of failures. Because I would argue that the major failures we've seen in orthopedics have not been predicted. The failure of metal-metal, the failure of modular implants, they were not adequately predicted by the preclinical tests that were being done. Improve computer algorithms to better predict wear and performance in silico, better mathematical modeling techniques, taking advantage of advancements in computing technology, and also simulation of our reconstructions. Further understanding of tribocorrosion, what drives it, and I think just as we've improved the performance of polyethylene with good, hard, basic material science, I think we can do the same thing with metals if we understand the mechanistic aspects of tribocorrosion. And finally, new engineering tools and performance analysis, and we'll probably talk more about that in the discussion section. So with that, I will introduce our next speaker, Kay Poelstra, and thank you very much for your attention.
All right, good morning, everybody. Unlike the two prior speakers, I'm losing my hair. I don't have a lot of gray hair yet. I've been doing orthopedics for about 20 years now. My font is a little smaller, so I'll look up there. I live in Destin, Florida, and I'll tell you a little bit more about this around the 10 o'clock session in the surgeon pod. I am sort of similar to Dr. Jacobs here, the funnel where things get bad. Everything south of Atlanta and Birmingham seems to find me on the coast. I was highly academically trained. I worked at shock trauma. I had my own lab. I had a bunch of NIH funding there. Then I had 4 children in inner city Baltimore. And me and my wife, who's a neuroanesthesiologist, decided to raise them elsewhere. And that brought me to Northwest Florida. And some people say, inappropriately, it's the redneck Riviera. There is a lot of questionable healthcare, to be perfectly honest, not throwing anybody on the bus. But I got there with the idea to do trigger fingers and carpal tunnels and maybe an occasional ACDF. And it turned out it's an entirely underserved population where there was a lot of iatrogenic deformity, right? Surgeons that tried to do reasonable things with maybe inadequate skills and training and left patients horribly kyphotic. For people that do orthopedics and not spine, that's when you stand forward, right? So the outcome of spine surgery is directly related to the ability to stand up straight. So I suddenly built a practice with a tremendous number of large osteotomies, giant constructs, and things that nobody had seen in that area. And I do long construct, primarily more minimally invasive procedures, because I realized from being in academia, especially at shock trauma, where people came in 2 pieces and we put them back together. If there was a problem, the resident got called, he got with the medical student and the chief resident. If there was a real problem, the fellow got involved. I never knew about gaping wounds, large infections, and all that kind of stuff. Because, with all due respect, in academia, you're pretty shielded from that stuff because there's multiple layers of things and people that prevent you from your phone call. If you are by yourself in the middle of nowhere on the beach and there's a problem that somebody needs more Tylenol, you as a surgeon get the phone call. So you can imagine if you start to have patients with infections, open wounds, terrible things after massive reconstructions, I suddenly realized, things need to change. And this is more than a decade ago. So we started to pioneer minimally invasive surgery as a means to possibly help patients with a similar problem, but being able to do it in a more minimally invasive fashion with less wound complications and so on. So this has come to a field way beyond what the industry expected. When I was at Shock Trauma in 2005, 2006, 2007, we started doing 1 or 2 level minimally invasive constructs, and some of you may have helped design some of this stuff, the early days of Viper and Sextant, for example. But no company had ever envisioned that we would do 10 or 12 levels MIS surgery, right, in the future. This was bottoms-up development from the surgeons, and I know we are maybe more entrepreneurial and tinker along without looking at the evidence. Yeah, that's maybe true, but we tried to solve a really bad clinical problem, right? So we were ahead of the science, and I think now you can see when you go to some of these spine meetings, they have picked up on this MIS type thing, and it's really become like the next wave in spine surgery, right? And if you look at companies, I mean, that's the field that they're growing in the spine world. So that's what I do. I do long constructs, mostly MIS type surgeries, and I try to improve upon bad things that happen, unwanted variation, because that's the thing that drives healthcare cost beyond belief. Variation isn't bad, right? Because variation makes one surgeon maybe a little bit better than somebody else because he's better at doing it that way. Unwanted variation leads to readmissions, infections, prolonged hospital stays, and all that. So whatever we can do to reduce that, that's sort of where my focus is. So I do everything across the adult gamut of spine surgery. We treat a lot of patients with cancer in our little town, and I've done more than 700 robotic spine surgery cases nowadays, and together with Izzy Lieberman and Dennis DeVito in Atlanta, I think we've done more than anybody else in the world with this because we want to try to automate part of spine surgery so it doesn't go as unfortunate as it has been doing for a very long period of time, simply because of you can't know what you don't know. So if the robot tells you how you should do it, how great would it be to improve the outcome for your patient? I have a history of a Ph.D. in implant-associated infections with Anthony Christina in Northern Virginia after he moved there from Wake Forest. We looked at IgG coatings and coatings on implants, coatings on suture material, and the use of IVIG in a local fashion to be ahead of sort of this complement response that usually takes a couple days, right? And that's where these infections are coming from. So this was in the fear post-antibiotic era that you guys may remember, right? When MRSA and VRE started coming up. So that's initially where we started looking at implant infection problems, and we developed novel materials, and I did some stem cell work with Giron over at Shock Trauma also to look at nerve recovery and spinal cord recovery. My PhD eventually was defended in Holland at the University of Groningen, and some of you may know that there's a large biomedical engineering department. And when I was a little boy already in my residency, I wrote letters to the FDA and I said, you know what, I don't really understand, and I was very naive, right? We have titanium, cobalt chrome, and we have some plastics, and we do a little bit of a stainless steel. But the industry around us that flies planes and space shuttles and all kinds of stuff, they have access to stuff that we should really use in people. And I will present to you around 10 o'clock the advance, and we'll talk about it now, of a new material called molybdenum rhenium. Implants were just approved late April, and I think this is going to broaden the scope of what you guys are doing from those really 3 main metals, some plastics and some bioresorbables, to a new metal with greatly superior biomechanical properties. It has a greater wettability, you can print it, you can do wonderful things with it. So it took about a 10-year quest to get this thing approved by a company in Atlanta. So I am maybe entrepreneurial, that's not my research, I'm sort of explaining this guy to you guys, and we can talk about offline a little bit later what the implications potentially would be. But there are spine implants now approved, foot and ankle implants approved from molybdenum rhenium, and we'll share with you the material properties and the type of implants that can be created from this. So this started when I was a resident, and finally, you know, another 20 years later, here's where we are. I must admit to you, no matter how I love the Emerald Coast, I think automation in spine and computing technology combined can be only advanced at a level that we need in Silicon Valley. So I am transitioning from the Emerald Coast in Florida to Silicon Valley to build a whole new robotic institute surrounding spine surgery. I'll be a busy spine surgeon hopefully there, but it hopefully is a proving ground for new advancing technologies in spine, and hopefully that will flow over to other robotic and automation technologies in other fields of primarily orthopedics. What has worked and what hasn't worked, and maybe we'll touch on this a little bit later when we go through the panel, but I think 3D printing and osteointegration was already discussed, right? I mean, that's been wonderful for us. We always talked about fusion, right? That's the biggest thing now. If you put a titanium 3D printed cage in the interbody space, you fill it with bone graft, on day one on the CT scanner, it looks like it's fused. It's obviously not fused because you just put it in and you can take it right back out. But this sort of cleat-like interface between a 3D printed metal and bone has tremendous advantages. Clinically, you see it because patients feel better than they used to do when you put a PEEK implant in them. They still had a sense of some micromotion despite putting in pedicle screws. If you put a large footprint 3D printed material in there, these people get up and they move and they don't have the same type of back pain. Now the difficulty we have, does it have to fuse? Maybe not really, because as long as there's like 1 or 2 millimeters of some osseointegration to those pores in that 3D printed object that's in there, patients are stable and they're fine, right? So we're having a quest now of trying to figure out how we can visualize this, and maybe we can do this with something we'll come up to a little bit later, to put something smart inside of these cages that can tell us on our iPhone if the stress that you can measure through the cage has gone down, meaning there must not be just loading of the cage, but there is actually solid bone formation going across. MIS spine surgery, we talked about it. The difficulty with us is that we don't really have a definition of MIS spine surgery, right? Everybody's an MIS spine surgeon, whether you operate through a tube that's 14 millimeters or you make just a little bit smaller incision than in the past. Everybody does MIS spine surgery, because if you don't put it on a billboard, right, you have no business anymore. So that's a little bit difficulty, but I think that everybody agrees that less is more in this case, right? The smaller you make your incision, the less soft tissue disruption, the less inflammatory cascade you start on a patient, the fewer phone calls you get about post-op pain, and the faster people obviously heal. And then the molybdenum rhenium, we talked about that. I have some great data to present around 10 o'clock. Greater durability, stronger, it has much less recoil. So as a spine surgeon, bending rods to make a patient's spine straight, the last thing you need is that you bend a titanium rod and you have a 9 to 15% recoil, right? Because then you have to overbend it and it bends back, and then you got to do it 2 more times and the durability is hurt. And not a lot of spine surgeons understand that, right? When you bend a rod one way and the other way and then you go back to the first way, your durability of titanium is like 17% less. But we need to get away from that, and we need to educate people better. And I think with having a new metal, we have to start thinking of complete different ways of being able to do surgery, right? So far, we've relied on 5.5 millimeter or bigger rods. Suddenly, we can achieve the same thing with 4 millimeter rods and smaller, maybe. So we can change the way we attach things to the spine, and we can do it in a much more minimally invasive fashion and with less recoil and less ability not to depend on the implant to look the same the way you put it in and that it's going to come out. We can have maybe robots do something much more predictable than a rod that is potentially a lot more flexible at the end of a rod holder, if you think about it. If I move a rod holder with a stiffer rod, then the robot should know where that tip of that rod is. If the rod is relatively forgiving, well, then you might do really bad things if you have automated tools to eventually place your implants. We talked about robotics. I think there's a lot of good things that are coming out of this. We're in its infancy completely, right? And I think the next speaker will completely agree with that. It's first generation, but it's really spectacular, I think, what we've been able to do and how we are now thinking differently about procedures than before. Hip and knee replacement with a robot still has to be done fairly similarly. I think we have to change our thought process that robots don't have to mimic what we do, right? We have to do a good procedure, but a robot might be able to do something completely in a different fashion to get to the same endpoint in a much more efficient way. And we just have not been able to do that because we need to make holes and stick things in there and be able to see most of the time either with X-ray or direct optics. But robots might be able to do things underneath surfaces with image technology that we can't even think about right now. So I think we have to get away from the fact that a robot should mimic what we are good at. Robots can potentially do something entirely differently than what we're currently doing. Things that haven't worked, and I don't mean to hurt anybody, but I think facet replacements, you know, there's some companies come and gone, and there are some new companies now coming up from the past that are trying it again. Hasn't done really well. Well, we talked about tribology before and making things move. I mean, we're in its infancy in spine, right? We want to make things stiff and stable. We do disc arthroplasty in the neck relatively successfully, also with metal bearings, but the lumbar spine has never done very well. Adjacent segment motion is a huge problem, right? If we fix a part of the spine, there's a stress riser at the top, similar to when you do metallic engineering. And unfortunately, people fail as time goes forward. And we can't settle and be excited for maybe a 30-year spine, right? You would be very excited about a 30-year hip. I need to have like a 60 or an 80-year spine, right? So we have to find different ways to help patients with a long fusion to make sure they don't break down at the junction between motion and stiffness. And then, in all honesty, there are some patient-specific implants, right? There is like printed rods that are coming out of a company in France. You send in your scan, and you do your measurements, and then it goes there, and then 2 weeks later it goes back. I think it's neat, but it's not necessarily cost-effective. There's not going to be more payment for a patient-specific implants, at least if we're talking to spine here, than a non-patient-specific rod. So also the patient-specific rods that are bent in the operating room with a tool called Bendini from Nuvasive. It's very neat, but it's not so great maybe. There's a computerized bending system called Arcade from the Mazor Medtronic people. But then the problem is it comes out of the machine, and then it still needs to be sterilized. So that's a window that you're sort of missing in the operating room. So I think we're certainly not there yet. And let's not talk about lasers, because they just put 1,000 people out of work when the Laser Spine Institute went belly up. So that was a very unfortunate thing. Current trends, and I'll run through this a little bit quicker. Automation, right? I think everybody agrees that this unwanted variation needs to be reduced. Robotics and automation are the key to this. Computing power is increasingly more fast. So I think there's a tremendous opportunity there. There are companies called 7D that do things similar to what the Tesla does, right, with optics. The disadvantage is still you need to look at the spine as opposed to keep the skin closed and ultimately get some kind of X-ray or potentially ultrasound to see in real time what's going on underneath the skin. The 2D and 3D ability to figure out where the spine is in the operating room is going to be key, right? We just talked about the better you get your patient upright during surgery, the greater the chances for a good outcome. So if we have real-time tools that are tiny Wi-Fi powered sugar cubes in the operating room attached to a couple spinous processes, and I do my osteotomies and interbody corrections and so on, and the computer can tell me, yes, grandma is now in the right position on the table, then I know I can lock her down, and I know that I've done a good operation. And that information is currently lacking with the navigation systems that are granted from the late 80s, early 90s, right? The refresh rate is not up to par, the accuracy is not up to par, and it's cumbersome to use with all these fiducial balls and things like that that you guys are well aware of. We talked about smart technologies, right? I think this is the key for 3D printed structures, let's say, wherever they're going to go, to see if there is just loading of the structure, or if the microstrain sensor that is also Wi-Fi powered inside of an implant can tell us that the metal is no longer loaded. There's actually bone that is growing, and the bone is sharing the load, and it shares that with the patient's own phone, along with patient-reported outcomes, devices, smartphones, Fitbits, those kinds of things. It goes directly to the office, so we can intervene, and we know exactly what's going on with the patient, and can tell them, yes, I know you're a workers' comp case and your back still hurts, but it's not just a picture. We can show here that your spine is fused and that it's time to get up and go back to work. Technology hubs, I think, again, not to criticize anything, academic centers are relatively slow to adopt and adapt. And it's hard if you're a well-respected professor and there's very fast new technology coming, that you have to go back and learn that. I think I have tremendous respect for when I do these teachings on robotics and advanced MIS techniques and other things we talked about, and I have people that were the gurus that I was taught by in the past, and they have the humility to come down and say, you know what, I want to learn these new things because I think the people I am training should learn that in my center, in my residency. Because what happens nowadays is that a spine surgeon trained in a well-respected fellowship today is probably learning exactly the same thing that I got taught 15 and 16 years ago, and he has to go out and then find new ways to the lateral spine and so on his own to go through courses and all that, because most of the time the older attendings have never caught up to the new approaches to the spine, like the X-lifts, robotics, and so on. Academic centers are very slow to adopt, and it's not to their fault, but this is what we're dealing with. So when surgeons are coming out, they are going two ways. They either need to have very high demands for advanced technology to do their cases if they were in a fellowship program or so where they were advanced. If they weren't advanced, then they have to go out and learn all these new things. Otherwise, they do still big open surgery for cases that really should be done in a much less destructive way for the patient. And I think this is a hurdle that we have to get over as an industry and academia and private practice together to maybe have combined fellowships and so on. And then there's difficulty to get paid, right? We all want new things and better things, but unfortunately it's very costly. And the problem is that reimbursement is always going down, right? From here on forward, you will never get more money for your new pedicle screws and your new widget and so on. So if we talk about molybdenum rhenium and smart implants with devices inside that cost money, it is an uphill battle to get hospitals to accept it because they don't see more money from Medicare or insurance payers coming in to do the surgery with those implants. So they just see us, you, as kind of greedy, and you make so much more money than the hospital margin of 4 to 6%. So this is something we have to be cognizant of, and I think unless the industry binds and ties somehow with hospital systems and insurers together, it is going to be difficult to keep up the pace of innovation and engineering that is possible because there's simply no money for it. I'll stick to that, and we can have some time for discussion later. Thank you very much.
Thank you very much.
Morning. So as Dr. Jacobs said, I am also an adult reconstruction surgeon. I actually did my fellowship with Dr. Jacobs at Rush in 03, 04. So if there's anything that you have a problem with that I tell you this morning, take it up with Dr. Jacobs. It's his fault. So I'm in academic practice in New York City at Mount Sinai. And I started a company about 3 years ago called Monogram Orthopedics. And I've been encouraged at this conference to hear that a lot of what we're working on at this startup of mine are kind of common themes, and that the industry seems to be kind of buying that we're going toward customized implants and more advanced robotics. So that gives me hope that we're on the right path as far as my company goes. I got into startup orthopedics because I was a consultant at Think Surgical, which you guys may know was the offspring of RoboDoc, which was actually the first FDA-approved robot before Da Vinci, before any other robotics. RoboDoc back in the late 80s, early 90s was the first robot of any kind that was used on humans. I got involved with them after they got some financing to kind of commercialize the technology, and I was with them for about 5 years. And what I saw was the potential for robotics to do more than what we were using it for, which is to kind of do the same old surgeries with maybe a little bit more precision than we've always done. But we could actually use robots to do things like put in custom implants. And I'll talk a little bit more about that later. But so that was kind of the impetus for starting Monogram, to essentially couple custom milling with a special robot with custom implants that are 3D printed, and to kind of get that perfect fit and improve upon joint implants. So what's worked in my experience? So robotics. So as the last speaker said, we're still in the first generation of robotics in orthopedics. It's kind of, the stuff that we're using now is kind of like the Commodore 64 Atari, compared to what's out there in the world of industrial robotics. The technology that's in the machines that we're currently using in orthopedics are relatively primitive compared to what you would find in like a Tesla factory, for example. They're also very expensive technology because, like Moore's law, the technology, the cost of robotics technology has continued to fall. So, where we're now paying, $1 million plus in capital expense for an orthopedic robot, really the cost of these things is coming down precipitously. So you can get a state-of-the-art cobot from one of the big industrial robotics companies for $40,000, $50,000, $60,000. So I think what you're going to see in robotics is the technology is going to improve while the prices are going to plummet to the point where companies will essentially be able to give the hospital the robot because they'll be using the robot to drive implant sales. So even as primitive as the current technology that we're using is, it's still really good. And it has, over the past 10 years or so since we've been using orthopedic robotics, it's gained adoption steadily, and it's not going anywhere. And part of the reason for that is that we're starting to see some data. We're actually starting to see some midterm data on partial knees that were done, in 2009, 2010, that show improved survivorship over manually done Unis. So that's the kind of data that some surgeons that they're not necessarily early adopters need to see to kind of say, okay, this technology is worth it, and I'm gonna buy into it. Big thing that I'm seeing in my practice, which is kind of disheartening, is that people like sports docs in the community that were sending me partial knees and total knees and that kind of thing are taking a look at the Makos and some of the other robotic technology out there and saying, you know what, I can do this. And so now sports guys who don't really have training in knee replacement surgery, certainly don't have any training in partial knee replacement, they're doing them because this technology is so good that it takes an operation that is pretty finicky if you do it manually, and turns it into something that's much more reproducible for kind of a lower volume sports type surgeon. So another thing that I find works for me is I started doing these things called kinematic knees about 3 years ago, and it's kind of a controversial topic in joints, but I think we're starting to see some data that when you do a kinematic knee where you're kind of resurfacing the joint rather than kind of changing the angles that you put the implants in, you get patient satisfaction scores that are approaching total hip levels. There's this 80% satisfaction, good to excellent satisfaction rate in total knees, and I think Dr. Jacobs might agree that elusive 20% of kind of not super satisfied knee replacements is still out there. So we're still chasing that 20% of knee patients, and what I'm seeing with kinematic alignment is that we're getting a little bit closer to that 90+% good to excellent patient satisfaction rate. We're also learning that there's data coming out showing that if we put the tibia in a little bit of varus, which is how most tibia's native anatomy is, that it actually is not going to affect the survivorship of the implant. There's a big study that Mayo came out with a year or so ago looking at 20-year data, and they found that even in outliers where they put the tibia in more than 5 degrees of varus, there was no difference in revision rate. So that's added fuel to the kind of the adoption of this technique. So dual mobility hip replacements, I think, is solving a problem. We're learning more, and you all probably heard about the kind of evolving knowledge base of the kind of spine pelvis connection. There's more and more research coming out on this. We're understanding it more and more all the time. But there certainly is a connection between the spine and the pelvis, and dual mobility implants can really help with solving that problem. There's one paper that has been recently published showing a 7-fold increase in dislocation rate after a spine fusion in a total hip patient. Another trend that seems to be working is outpatient joints. There's been a lot of talk about ASCs and the kind of the increasing prevalence of outpatient joints, projected to be over 50% of joint replacements in the next 5 or 6 years in the United States. So this is a trend that's happening. There's a lot of cost pressure, bundled payments on the system that's kind of driving this. And the data is reasonably good. You know, there's 30% reduction in cost of an outpatient joint as opposed to an inpatient joint. The surgeons have financial incentive often with ASCs that are driving things. The outcomes are being shown to be equivalent in terms of complication rates and readmissions and that type of thing. And we're developing better and better risk stratification tools to ensure the safety of outpatient joints and to make sure that we're risk stratifying appropriately for outpatient. So as far as what hasn't worked, I just picked a couple things out of my hat. Patient-specific instruments was a fad. I don't know did you ever do that? Yeah, I mean, I tried patient-specific instruments for knees a few years ago when it was a hot topic, and what I found is it really didn't help me. It kind of slowed the surgery down. The jigs didn't fit quite right. I bailed more often than I wanted to manual instruments, and honestly, the data has not really shown superiority of PSI as opposed to manual. So I think it's largely been abandoned by surgeons. They're still out there, but I don't think nearly as common as it used to be. Cementless tibias are definitely getting better, but in my own personal experience and some of the data with older cementless tibial implants is not great. And I think that we're seeing a trend in moving toward more cementless fixation in knees. Our knee patients are getting younger. They're roughly the same age now as our average age for hip replacement. And so the idea of not cementing is really attractive, I think, to a lot of surgeons. But cementless fixation has in the past not been super reliable. I put in hyaluronic acid, just to illustrate something that I find in my practice, which is that patients really don't want to have joint replacement surgery, no surprise. And they will believe in just about anything that will give them hope that they can somehow avoid that surgery. And so viscosupplementation is kind of a prime example of that. The evidence is not good. It's horrible. And there have been lots and lots of good randomized controlled trial studies done, and it's placebo. And when I tell my patients the science behind it, they get pissed off at me, which is an interesting response. But because I feel like I'm trying to give them the science and tell them, no, this is not going to work. And more times than not, they think that I'm trying to talk them into surgery. So that's an interesting conundrum. So where I think the industry's going, and we've all mentioned this, 3D printing in metal continues to evolve. And so it's making customization of implants not only possible, but also practical in terms of time to delivery to the hospital and cost. So the cost is coming down for custom implants. It used to be that if you wanted a custom tri-flange hip socket, it would take weeks to make, and it was very expensive, and the images had to be manually segmented. So a lot of kind of emerging technologies are coming together to make mass customization of implants really not only possible, practical, economical, but also really potentially clinically beneficial. So if we're really careful about not just creating customized implants just for the sake of customization, but actually attacking real clinical problems, I think that there's a lot of potential here. It's also makes business sense. There's obviously a huge inventory issue with the big implant companies, so moving to customization will help solve some of that. And just the modeling, the software and computing power that's available to allow images to be analyzed and processed is getting better and better, and it's kind of facilitating the move to mass customization. Again, AI deep learning is kind of along those lines, which is going to support all these new technologies. I mentioned cementless tibias before. I think we're getting there. Some of the newer implants have better data, but again, I think customization and robotics can help quite a bit optimize cementless fixation in knees, and I think that's be interesting to hear your thoughts on this. I think we're going to be using cementless knees in 10, 15, 20 years like we do cementless hips, and we're not going to be cementing knees anymore in the medium term future. Smart implants, I think we've all kind of mentioned some variant of this, but I think we'll start embedding sensors to detect things like aseptic loosening, infection, stability, wear, knee motion, etc. And then last, I think that getting past that first generation of robotics to kind of the next generation, one of the things I think will happen is we'll start getting away from fiducials, like was mentioned in the last talk, and we will have machine vision. So the robot will be able to see what's in front of it optically. We won't have to place markers. It'll just speed the whole process up, make it less painful for the surgeon, and kind of get rid of some of the fiddle factor and really make it almost universal. I think that's it. Thanks.
Thank you. Thank you. Before we go on to our discussion session amongst ourselves, I thought I'd take a moment to see if anybody in the audience would like to ask any one of us a particular question or start off our discussion. So does anybody raise your hand if you'd like to pose a question, challenge something that you've heard that was said, or you want us to go into our discussion phase here? Don't be shy, please. There.
Question for Dr. Leska. Yeah.
Unis.
Unis, I'm sorry. Do you foresee, with this culture of robotics, do you foresee a bigger role in the OR for the robotics, such as opening, retracting, and closing? You know, aside from implant cuts and implant placement, do you see a bigger role?
As far as soft tissue management for joints,
Right.
I really don't. I don't think we're heading to Da Vinci-esque robots for orthopedics. You know, it's the utility, the value add for us is really CAD CAM. You know, because that's what orthopedic robots are. It's just CAD CAM. I just don't know how much value added there is for that type of automation. You know, it's not as delicate and fine surgery as, say, you know, open heart surgery or that kind of thing, or even spine surgery.
Anybody else on that?
I think it's a great question. I think where we sort of are thinking, right, maybe as more junior surgeons being excited about what happens in the world around us. I mean, nobody got here in a car that wasn't fixed by robots, right? It completely is put together, and there's just a couple guys on the floor that oversee in these new facilities. So we should not close our eyes for the fact that robots now can sew your jeans and your suit, right? Because of optics and machine vision, the textile industry has literally spent billions of dollars figuring out how to get people away from the sewing machine. And with machine vision, they've been able to figure out textile. And textile is very difficult, right? Because textile can move different ways, and it is stretchy and all this kind of stuff. So since that has been done, I know there is a robotic company pretty far along with actually being able to close universal wounds. So it's still not an exposure robot today, because that might be bleeding and bovies and, you know, all kinds of stuff. But if you have a wound with a reasonable amount of anatomy, with the fascia, subcutaneous fat, and then skin, we're very close at just telling the robot, okay, look at it and close it up. And the soft tissue tension is going to be better than any adult reconstruction surgeon will ever do per stitch, right? Certainly better than the medical students and the residents that normally get left to do that job, leading to maybe the 1% infection rate and so on because of dragging tissues and stuff like that in the wound from the skin. The suture thread touches things it shouldn't be doing. Right. So I have great hopes that, in all honesty, and just remember this meeting, between now and 10 years from now, a simple, at least in the spine, operation will be done 75% by a robot. I really think so, because of the machine learning and the ability to be able to see and then close the wound in a more predictable fashion. So it is very close.
Right.
It is very close.
No, I'm optimistic with that. Thank you.
I think from a soft tissue standpoint, though, what's, at least in joints, what's valuable is assessing ligament tension, you know, and balancing the knee. And what I'm seeing with robotics is that it's completely changing the paradigm of how we balance knees and how we think about gaps. You know, I talk about kinematic knees. When I've seen surgeons use the Mako that are not kinematic surgeons, they're actually doing some variant of kinematic knee replacements because that's what the computer is telling them to do, because that's where the knee wants to be. So that's the value soft tissue-wise, that we're getting information that we just didn't have before.
Sure, sure. Yeah. That's great. Thank you.
Thank you very much. Actually, while we're on this topic of robotics and knees, I would actually ask Dr. Jacobs to jump in on this, being a knee surgeon for 30 years, and his thoughts on where we are today and where we're going with robotics, and actually any advice he could give to the engineers in this audience on what they should be thinking about that could help him in the OR with the current technology, taking it to the next incremental step.
So what I've heard from my two colleagues here is just a wonderful vision of the future. It's really exciting and inspiring, and I sure hope we get there. However, where we are now makes me wonder, how are we actually going to get there? So I'd look to some of our sister specialties, urology, gynecologic oncology, general surgery, et cetera, where I think robotics is now the standard of care in many of these operations. And if you're not doing robotics with some of these operations, you're going to lose your patients to other medical centers that do it. The fascinating thing is, I think the evidence base to support it is a little shaky. There are some studies that may show some benefits of the Da Vinci in certain cases. There are others that maybe aren't as supportive. And so, being the kind of the curmudgeon-y, gray-haired academic in the panel here, I'm going to be convinced with evidence. And so all of what we heard today, of all these really promising, bright technologies in the future, unfortunately in orthopedics have led us astray in some cases, and have led us astray badly. So for example, this afternoon I'm going to do yet another interview with a national news organization about metal-on-metal bearings. And the current concern has been brought up on the Netflix video, The Bleeding Edge. Have anybody seen that, Bleeding Edge? You know, please look at it. It's not necessarily accurate. Actually, it is not accurate. It's horrible journalism. It's unbalanced. Yet that's what the perception is of your industry and of our industry to some extent, and the FDA. And so, again, these things keep coming up. Anybody see the John Oliver segment on orthopedic devices based on the Netflix interview? Google that one. Another scathing rebuke of our industry. So the point I'm making is we need to be very deliberate and put the scientific process in view, particularly clinical trials, well-designed clinical trials, randomized controlled studies where possible. They're not easy in surgical disciplines, but they're possible. Because not only is that going to give us confidence that the new technology is going to be an improvement, it also can protect us against some of the disasters, and perhaps more to the point, it will get people to pay for it. And because as Case mentioned, That is a real challenge with some of these new technologies. In this era of declining reimbursements and bundled payments, where now even the surgeon's incentivized to not use new technology because they'll make more money if they use cheaper implants. It's the bar is getting higher and higher and higher for this new technology to get introduced. And the way to do it is to have the evidence. Now the challenge is, how do we get that evidence, and how do we do it in a way that's affordable? Because doing clinical trials is very expensive. That's another matter. Whereas I look to the promise of robotics right now in its current form, and I think others mentioned, it would just slow the surgeon down, and my high volume, very successful surgeons in my institution don't want to get anywhere near it. It's going to slow them down, and it's probably not going to improve their outcomes one iota.
Yeah.
Thank you.
I could not agree more. Let me just give a slightly different view of that. I fully agree that a fool with a tool remains a fool, right? So you can't make the sports medicine doctor was thrown a little bit under the bus, but I get your point, right? I mean, people that are not trained to do something suddenly may think, hey, I have a tool and I can suddenly do this just as well. I mean, that's obviously not true, right? So you still need to be very careful. But I can tell you that at least in spine, where the robotics industry is excited about new developments. There's 4 companies that will have robots soon or have them right now. We've done the first studies both retroactively in more than 700 patients, and then we did something called the refresh study, which was a prospective study, and it clearly showed a 6 odds ratio reduction in revision surgery for long construct MIS, adult scoliosis correction, and an 8-fold less odds ratio, of 8 of lesser complications across the board. And this is not just because of the robot. This had to do with patients that had that type of surgery with the robot had less soft tissue inflammation and dissection, so they got out of bed earlier. So the DVT rate was lower. Their pulmonary complication rate was lower. So it's not that when you use a robot, suddenly the patient won't have a post-op UTI. I mean, those links are not there in spine, of course, directly. But motion is lotion, right? Early mobility protocols aided by less traumatic surgery will help patients to get out of bed and have a reduction in complication rate, revision rate, readmission rate, and so on. So there is indeed, to your point, a wealth of enthusiasm, and we almost try to outpace our own evidence. But I think that the guys that are doing this carefully, and we were part of this early study with the early adopters, right, have shown that there is a tremendous benefit for this. And robotics are a little different than implants, right? Because what you mentioned, what is primarily like being touted to the general public is mostly like implant-related stuff, right? You give us something, you get paid lots of money, but it wasn't tested well enough, and oh my God, now there's a complication. It completely goes away from, was it put in correctly? Was the indication by the surgeon correct? Was the, there's millions of things that are not nuanced in there. So, but we have to be careful. We have to be extremely careful with this. But I think the future is bright, and as long as you're willing to take a little bit less money for more advanced technology, I think together we can make it happen.
Thank you. Does anybody else in the audience have another question that they'd like to ask us before I pose my own question to the group? Over here, please.
I think this will have to be our last question.
Okay.
Okay.
Oh, yeah.
No pressure. I've been in the industry for probably about 20 years, and I've seen a lot of change in orthopedics, and the speakers on hip and knee, I've been involved in hip and knee for a long time. My concern is with the industry and pushing the envelope of advancement. One of the issues I think we're going to face with the new MDR, with post the ASR issues, is the more regulations that are going to come in and how that's going to slow down the advancement in the future. I don't know how the panelists feel about that, but I'm excited about robotics, but as Dr. Jacobs just explained, there has to be evidence-based. It's going to cost a lot of money to advance. And my concern is the industry, how I've seen it go very quickly and have some more advancements in technology. I think now through the new MDR, that's going to change, and I think that's going to slow a lot down, and it's going to cost a lot more money. So I think we'll see a big slump in advancements. And unfortunately, in the earlier years of my career, there has been mistakes, there has been problems, but that's created an advancement in what's happening. But I wanted to see what the panel thought about that, and how we can, as an industry, keep innovating, but keep safe is one of my concerns of how we can keep that speed that orthopedics has had in the past.
Yes, I'll take a crack at that. And you know, our regulatory agencies, the MDR in the case of the UK, the FDA in the case of the US, they have a very difficult job, almost an impossible job. And I've had a lot of interactions with FDA folks over the years in various roles, and have advised them on the metal-metal issue, among other things. And striking that balance between innovation and safety is a real challenge, particularly when we don't have the science to do it. And so one of the ways that I would advocate going forward is that we need a more robust regulatory science. We need to have ways to predict how implants are going to do and not run the experiment by putting them in patients as much. It's always going to be an experiment. We're always going to be doing simulations. But we have to work on our regulatory science approach to make our simulations have more and more fidelity. And that's some of what I was saying about what the future could hold for us, is to have preclinical testing much more nuanced, much more based on analysis of failure mechanisms, using the advances where we get from some of the big data approaches, having much more information on phenotype, genotype, omics, information on potential biological factors leading to failure. As we come up with better predictive modeling, I think we can do a better job in producing safer implants. But that's going to take a concerted effort by a lot of scientists, regulatory agencies, and other stakeholders.
I would just like to add, can I say one last thing? You know, I think the challenge that we're going to face in the near future is that, you know, customization is happening. You're going to see more and more custom implants, and how do we regulate that? How do we test those? How do we decide kind of what the bookends are of custom implants? And then also new manufacturing techniques like 3D printing, which is rapidly evolving. Like, these machines are changing very quickly. The technology is changing. So, you know, how do we regulate that? I think those are going to be huge challenges that I don't think the regulatory bodies have really figured out yet.
Yes, we're going to have to leave it there. Thank you all for joining us. Dr. Poelstra and Dr. Unis will be speaking in the Surgeon Pod later today, and I'm sure these gentlemen will be sticking around to answer your questions. So thank you all very much for sharing your insight with us.